I would like to welcome you all to today's webinar, which is on Medicaid Managed Care 101, Building a Common Understanding for the Healthy Students Promising Futures Learning Collaborative. We're excited you all could join us today and hope that you enjoy this webinar. My name is Alex Mays, and I'm the National Program Director of Healthy Schools Campaign, which is the organization that is hosting today's webinar in partnership with Trust for America's Health. I'll be moderating today's webinar, but just wanted to start us off quickly by going through some logistics for today's webinar. Our webinar is going to run for about an hour, and a recording of the webinar and the slides from today will be available to view. We'll be sending out a link to that recording and the slides following the webinar. You should get it either hopefully by early next week. We'll get that out. And we'll also archive the recording and the slides on Healthy Schools Campaign's website where you can access them. Also, at the end of the webinar, we have a very quick survey just asking you to share your thoughts on the webinar, and it's also a chance for you to share any additional information related to today's topic that you would like to have more of. So we would greatly appreciate it if you could take the time to complete that survey. It shouldn't take you more than a couple of minutes. Also, I want to say that we're going to save time at the end of the webinar today for a question and answer session. So you can ask questions by typing the questions into the questions box on the control panel on your screen and clicking the send button. And we'll be collecting those questions throughout the webinar, so please feel free to send them at any time throughout the webinar and presentations, and then we'll be sure to collect them and answer them at the end of the webinar, and encourage you to do that throughout. So we have two wonderful speakers joining us today. We have Lena O'Rourke joining on behalf of Healthy Schools Campaign. Many of you already know Lena, who's been doing a great deal of work to support the Healthy Students Promising Futures Learning Collaborative, and we really appreciate her taking the time to join us today. In addition, we're also joined by Ashley Gray from the Institute for Medicaid Innovation, where she's the Health Research Associate. The Institute for Medicaid Innovation is a nonprofit organization dedicated to generating and disseminating evidence that demonstrates the impact of Medicaid managed care on access to quality care for vulnerable populations in the U.S. Previously, Ashley served as the Director of Federal Policy at Medicaid Health Plans of America. Ashley came to her current position from Avalier Health, which is a DC-based healthcare consulting firm, and she received her Master of Public Policy and Health Policy from the Thomas Jefferson Program for Public Policy at the College of William and Mary, and was a Chancellor Scholar at Vanderbilt University. So Ashley, we thank you for joining us today as well. So without further ado, I wanted to hand it over to Lena O'Rourke, who is going to provide some background for today's webinar and get us started. So Lena, take it away.
Thank you, Alex, and my thanks to the Healthy School Campaign and to TIFA for their support of both the collaborative and for allowing me to participate today. My job is going to be to set the stage for Ashley, our amazing speaker, she's going to provide a lot of context about Medicaid managed care and what it is. But I just want to make sure we're all on the same page and give some background. So next slide, please. I want to acknowledge up front that the Healthy Schools Promising Futures Learning Collaborative is the bulk of the participants on this call today. The collaborative was developed by the U.S. Departments of Education and Health and Human Services and is supported by the Healthy Schools Campaign and Trust for America's Health. Next slide, please. We have currently 13 states that are active participants, and thank you to all of the members of our state teams for joining us today and for making the time. And we're still growing, and we welcome to this call members of other interested states. Thank you for joining us, and hope you find this information useful. Next slide, please. The Learning Collaborative remains committed to its goals, which at its broadest level is trying to figure out strategies to increase access to school-based health services using a range of innovative tools and strategies, and by leveraging the partnerships between education departments, Medicaid, stakeholders, and school districts. And the state teams are actively engaged in building partnerships to improve access to health services in schools, improving state-level communications, and identifying funding sources to seed delivery models. Next slide, please. State teams are brainstorming strategies to expand access and include thinking about really new and emerging delivery models, and are looking at concrete examples of how other states have expanded to see what can be carried and what the best practices are. And really at the center of all of this, and the center of a lot of our conversation, sits managed care and Medicaid managed care, and that's why we're all here today. And consistently we have heard the theme from state team members that they want more information broadly on managed care and how it works. So that's what we're doing today. Next slide, please. The bottom line, Medicaid covers lots of people, including lots of school-aged children through managed care arrangements. More than 70% of all Medicaid beneficiaries are enrolled in a private managed care organization. And almost 9 of every 10 children who are enrolled in Medicaid and CHIP get their care through a managed care arrangement. 39 of 50 states rely on managed care to cover some or all of their beneficiaries, which includes all the states and the Learning Collaborative. And in 2015, 2 years ago, 32 of the 39 Medicaid managed care states covered 75% or more of their kids through Medicaid managed care. So it's important to remember when you see these statistics that this is a broad and growing delivery system in Medicaid. But remember, I really don't need to tell you guys this, but remember it anyway, that every state's program is really different in terms of its structure and its financing and its benefits. And we're going to be talking pretty big picture here, but remember that who managed care covers in each state will vary dramatically. Next slide, please. Conceptually, managed care plans in Medicaid are very similar to the health plans that we're all familiar with. Plans contract with the state to provide a specific benefit package, and then they deliver the services using a network providers, just like we're used to. But Medicaid has some additional and really critical consumer protections that ensure that beneficiaries get a robust package of services that sets it apart and makes it different from how private plans work. There can be differences in how that play out, but for example, children in Medicaid are guaranteed the full EPSDT benefit, and that carries over for kids who are covered in managed care arrangements. But states may do that differently in terms of what services the managed care company covers and which the states do. So there are going to be critical differences across the states, but the core Medicaid premise remains the same. Next slide, please. So putting this all together, this is what we know. We know that millions of children are covered by Medicaid managed care, which means that millions of students are covered by Medicaid and are in managed care arrangements. We know that schools and school districts work with health plans already. In some cases, schools work with managed care as partners to advance a community-based or population health initiative, like outreach and enrollment. Just last week, we spoke with a wonderful program, part of the California Learning Collaborative, that's doing a really neat teacher training and school-based outreach and enrollment that's funded by health plans. In other cases, schools partner with the managed care plans as providers and bill for services. And some are part of networks and some are not. And there's no right or wrong way to do this, but schools are partnering with plans now, and it's thinking about what works for them and what lessons we can transport. So it's really important that we all understand what managed care is and what the plans do. And so today's webinar is deliberately at the 101 level so that everyone can dig in deep on what managed care does in Medicaid, how it works, and how the plans contract with providers. Ashley's presentation is actually not going to focus on managed care in schools, but rather on broader managed care in Medicaid and provider contracting. So when you're listening to this, be thinking about the lessons that we can bring back into the schools and into the Learning Collaborative, but remember that this is 101. Be thinking of your schools and school districts as providers, and that will begin to set us up to think critically about how we as a Learning Collaborative can think about the partnerships between Ed and Medicaid to bring the schools and the managed care systems together and to advance our joint work. So with that very basic understanding, let me now turn to Ashley to start her presentation. Next slide, and Ashley, take it away.
Thank you, Lena. Hello, everyone. My name is Ashley Gray, and I am the Health Research Associate at the Institute for Medicaid Innovation. Next slide. The Institute for Medicaid Innovation is a 501c3 nonprofit research organization that is a wholly owned subsidiary of the Medicaid Health Plans of America Trade Association. The organization is focused on providing innovative solutions that address important clinical, research, and policy issues in Medicaid through multi-stakeholder engagement, research, data analysis, education, quality improvement initiatives, and dissemination and implementation activities. The Institute seeks to understand what works well in the Medicaid program, identify areas for improvement, and disseminate innovative initiatives and solutions that address critical issues. Advanced slide. Today I will spend a little time providing an overview of Medicaid and Medicaid managed care. I will follow with a little bit of a helpful insight into contracting relationships with Medicaid managed care plans that will hopefully provide some clarity into the contracting process and make it easier to approach Medicaid managed care plans. A quick note on linguistics before I get started. I will use the terms beneficiary, enrollee, and member interchangeably. All three terms refer to individuals that are enrolled in Medicaid and Medicaid managed care. Advanced slide. As you all may know, Medicaid was enacted in 1965 as companion legislation to Medicare. The program includes mandatory services and gives states the flexibility and option to provide broader coverage. As you can see on this slide, early and periodic screening, diagnostic and treatment, or EPSDT services, and family planning and supplies are mandatory items that are covered for the Medicaid population. These two services are those kinds of services that could be provided to school-aged children in a school-based health center setting. On the right, you will see optional items and services. These are those other services that are commonly provided in the state Medicaid programs. And you can see that there's a couple of examples here that wouldn't seem to be optional, but they are, in fact, but every single state offers them. So the first would be prescription drugs, another would be targeted case management, and the other would be emergency dental services. So while you can see that there's quite an array of mandatory and optional items and services, a lot of these are used and commonly found across the board in state Medicaid programs. Advanced slide. So how does Medicaid work? As you may know, Medicaid is a jointly funded program. That is, it receives a federal match for every state dollar spent on the program. For every guaranteed service provided to eligible individuals, the federal government provides between 50 to 73% of the cost of coverage, with no cap. Now, it's this structuring of the financing under Medicaid that is currently the source of much discussion among congressional members, and current reform efforts are targeted to restructuring the financing of that program. But we're not going to be going into that today. As far as the requirements around benefits are concerned, the Medicaid program grants states the authority to tailor their program to meet the needs of the beneficiaries in their state. This flexibility makes state Medicaid agencies the right partners for members of this learning collaborative. States have the flexibility in the administration of their program as well. They may choose a fee-for-service delivery system or a managed care delivery system. Medicaid managed care organizations, or MCOs, operate similarly to commercial insurers, or those that offer coverage for employer-sponsored insurance plans. Medicaid MCOs manage the beneficiaries under their care and take financial risk for all services provided. I'll explain this arrangement in further detail a little later. On this slide, please note the blue box at the bottom right. As you can see here, state Medicaid programs have the flexibility to set eligibility standards, benefits packages, payment rates, program administration, and provider certification. Each of these items is important to consider when partnering with state Medicaid agencies and more importantly, the Medicaid MCOs operating in that state. Advanced slide. Now I will further explore the differences between fee-for-service and Medicaid managed care. Advanced slide. The world of Medicaid managed care can seem complicated. I will not go into detail about the operation of the managed care program. Instead, I will highlight some differences between fee-for-service and managed care. First, fee-for-service is a financial arrangement in which a state Medicaid program reimburses clinicians for services provided to eligible beneficiaries. There is no clinical management team within the state Medicaid agency that reviews, analyzes, and coordinates care for these beneficiaries. This is something that the Medicaid managed care organizations offer, and that's the care coordination that you see on the right-hand side on that first line of the table. Typically, a clinician, usually a nurse, will manage a beneficiary's health and wellness records and ensure that beneficiaries are receiving the care and services they need for their condition. They'll also do things like make appointments, ensure those appointments are attended, and that medication is also adhered to. Secondly, as I mentioned before, fee-for-service is purely a financial arrangement in which payments are made to providers based on the volume of patients seen and the services rendered. Payments are set by the state in a physician fee schedule that are not contingent upon the quality of care offered, outcomes achieved, or medical necessity of the services. At times, this will incentivize providers to offer more services than may be medically necessary and does not incentivize them to provide the best care for their patients. The opposite is true under managed care. In managed care, MCOs are paid an established capitation rate for each member within a specified eligibility group from the state. What this means is that for each child, for example, with severe or persistent mental illness, the state will then pay the MCO a standard payment per month. Now, the MCOs will have to provide the full scope of services, both mandatory and optional, for these beneficiaries and manage the risk and health of their members with this standard monthly payment. This incentivizes the managed care organization to provide care coordination and ensure that their members' conditions are managed to avoid hospital admissions and emergency department use, all of which will cost the health plan more than providing their routine and preventive care. Additionally, payments to MCOs are tied to quality and value. Depending on the arrangement in the contracts with the state, MCOs may be provided with bonuses for meeting required quality metrics and providing value-based care. However, MCOs may also face financial consequences for patient noncompliance, poor quality outcomes, unnecessary utilization, and poor patient satisfaction. Advanced slide. Now that we've covered the basics of the differences between fee-for-service and managed care, I'd like to show you the growth of enrollment in Medicaid managed care over time. This chart is a little dated, but as you can see, starting from 1997 onward, we see a steep growth of Medicaid enrollees in managed care. Today, that percentage has reached 73%. This figure is really important. Each of the members of this learning collaborative are from states with pretty high enrollment in managed care. In some states, over 90% of Medicaid beneficiaries are enrolled in a Medicaid managed care plan. This makes it extremely important to consider working with them. Advanced slide. As I mentioned before, Medicaid MCOs are very similar to commercial insurers. They are focused on three broad goals: emphasizing primary care and prevention over treatment, contracting with quality providers, and providing appropriate services in the appropriate setting. Now let's unpack this a little. You may have heard the phrase, an ounce of prevention is worth a pound of cure. This is very true for Medicaid MCOs. They are focused on shifting services from treatment to prevention, keeping their members out of emergency rooms, and reducing hospital admissions. This means that MCOs prioritize targeted case management for members with multiple chronic conditions and seek to integrate behavioral health care services with physical medical services. To meet the goal of prevention, MCOs rely on a network of high-quality providers, including specialists. As such, contracting with providers that deliver high-quality care and manage utilization are a big priority for MCOs. MCOs also rely heavily on primary care providers for prevention and attempt to centralize a member's care through a medical home model. A school-based health center is a prime site to deliver primary care. It is also important that providers provide accurate, detailed, and timely billing to MCOs so they can appropriately manage the care of their members. Finally, given the financial risk that MCOs bear for their members, it is also important that their members receive the appropriate medically necessary care in the right setting. MCOs will frequently say that they need to meet their beneficiaries where they are. It is often hard for Medicaid beneficiaries, especially those parents of enrolled children, to manage multiple appointments in various locations. To avoid missed appointments and patient noncompliance, it would be very easy for a Medicaid beneficiary of school age to see their primary care provider and receive routine and preventive services in a school-based health center. Advanced slide. MCOs have three main relationships. One is with the state, one is with their members, and the other is with providers and facilities. I want to focus on the last two relationships specifically, members and the providers and facilities. MCOs are often required by the state to provide specific services to their beneficiaries. This includes health risk assessments, care coordination, chronic care and disease management, and quality monitoring. Each of these services requires the partnership of the MCO with a high-quality provider or facility. MCOs are responsible for credentialing each provider or facility, ensuring that they meet the basic benchmarks to qualify as a clinician able to provide care to the Medicaid population. Credentialing can be particularly onerous for providers to complete. MCOs will typically also facilitate the completion of that process. MCOs also provide support for clinicians and facilities who are treating their members. They will offer clinical guidelines, provide routine and regular reports to identify high-risk patients or unmet medical needs, and ensure that providers and patients are satisfied. Advanced slide. Now for contracting basics. I will do my best to make this as painless as possible, but recognize that contracting is not the most exciting topic. Advanced slide. MCOs consider a number of factors when contracting with providers. Let's focus on these four factors on the slide. The first addresses whether an MCO has a requirement in their contracts with the state to execute specific performance improvement projects. A state Medicaid agency may see that children enrolled in Medicaid in their state are not receiving their vaccinations according to the state's vaccine schedule, for example. In response, they may require MCOs to improve rates of vaccinations for their children. MCOs then take that requirement and have to execute performance improvement projects. One such would require the MCOs to be creative in their engagement with providers to ensure that children are receiving those vaccinations. They may have a contract with providers that have a higher likelihood of delivering services, targeting those providers like school-based health centers, for example. The second goal addresses an MCO's internal evaluation of the gaps in service or unmet needs of their members. In order to promote prevention and improve health outcomes, they may consider contracting with specific providers that will be able to accomplish that. The same is true for the third goal. MCOs are in the business of innovation to meet quality metrics, meet contract requirements, and improve health outcomes. If you as a provider can demonstrate an innovative approach tied to reducing costs while improving quality, MCOs may be interested in contracting with you. Finally, MCOs are focused on integrating the member and family voice in the provision of their care. They will look for providers and facilities that are capable of achieving that. This could come in the form of a school-based health center. Advanced slide. We discussed this a little bit in a little detail previously, but I want to expand on network participants. And what I mean by that is those providers that are contracting with the managed care organization to provide those high-quality services that meet state and federal regulatory requirements. It's those particular requirements that consist of the credentialing requirements, which, as you may recall, I said was a little bit of an onerous process. And that's where managed care organizations are really intent on partnering with their organization and facilitating that process so that they can make sure they contract with the right provider to provide those services. In particular, MCOs are in need of providers who offer services that achieve positive, measurable results that will improve quality of care and health outcomes. They also need providers that support healthcare affordability principles and utilize cost-effective approaches to services. While the care must be innovative and it must meet needs, it also has to demonstrate a return on investment for the MCO. Advanced slide. So what does the contracting process look like? There are more details in the process than are captured here, but I wanted to provide you all with a broad, basic sense of the process. The first step is probably the most important one, and that is working with an MCO to identify what they need from providers. And this means understanding where patients may have unmet needs and understanding what requirements the state has put forth for the MCO to accomplish. The next step is to complete the paperwork, which is, of course, everyone's favorite step. As I mentioned before, credentialing is one area where you will see quite a bit of paperwork, but the next is contracting directly with the MCO. And, you know, this can be a complicated process, but the MCO will likely be a very good ally in this process in identifying what's required and what's needed for this. And if you can demonstrate your value as a provider, an MCO will work as hard as possible to get you contracted and in the network. So the next step is to engage in contract negotiation. What will your MCO pay your providers? This could take some time going back and forth, but it's definitely a very big component of this contracting process. Finally, once the rates have been negotiated and contracts are signed, you'll have to store these documents, and a lot of states have specific rules and requirements about how long you must retain these documents. So it would be very helpful to connect not only with your state Medicaid agency, but also with your MCO partners about what questions you have for storing documentation and any other questions that you might have about the operational aspects of your contract. Lastly, you're going to need to engage with your MCO partner throughout the length of your contract. Really, the contracting process is just the first part of the relationship. What follows from that is constant engagement, utilizing support services offered from the managed care organization, any clinical guidelines that they may offer or require you to observe for their beneficiaries, and of course, keeping a constant copy of the MCO provider handbooks. And these are subject to change, but your MCO partner would let you know. And those are documents that you'd also need to keep on file. Advanced slide. Now that I've thrown all this information at you, how do you get in contact with an MCO? And this is probably the biggest question that needs to be addressed. The easiest way to do this, I would say, is to work with your state Medicaid agency staff that administer the state's managed care program. And I realize there are probably some state Medicaid agency staffers on the line, and so I welcome any questions or comments you have during the Q&A period. But these folks tend to engage with the right contacts at the MCOs. At the very least, they'll know who to identify and potentially broker a conversation between your organization and the MCO to get that conversation started about a partnership and what you could bring to the table and what you're looking for in support as well from them. The other, probably more difficult approach to identifying the MCOs that participate in your area and to get that ball started is to really kind of go through your state Medicaid agency's website or contact your partners and ask for those MCOs that are operating within your area. States vary on how they delineate contracts for different areas, so you'll want to confirm that you have the right plans in your area that you want to reach out to. And what you'll need to do then is see if you don't have direct contact information for folks at the plan, you want to see if they have a nonprofit foundation arm, and that's probably one of the easier ways to make that contact if they have one available. If not, you'll want to target business development, product development, or community program staff. These are the folks that either engage in developing those programs for performance improvement projects or would be your first line of contact to begin to discuss what contracting would look like with that organization. And I would say this is pretty tricky. You're not going to find these names or titles on the MCO's website usually, and even if you were to try to do a basic Google search for the product development lead in Virginia at Anthem, you're probably not going to find a name that pops up. And so this can be a tricky and time-consuming process. I wouldn't say that you'd have the best success rate with that arm. So bearing all of that in mind, I would really recommend working with your state Medicaid agency partners to see if you can gather the contact information you need and hopefully broker any conversations that you would like to have with the MCO. Advanced slide. Now that you've found the staff that you need to talk to at the managed care organization, you'll want to carefully consider what your organization can do to help MCOs meet their goals or required quality metrics. And so here I wanted to give you a small snippet of what managed care organizations are required to report quality data on. And so here you'll see, previous slide. The 2017 core set of children's health care quality measures for Medicaid and CHIP. In short, it's the child core set. And this is a set of quality measures that's developed by the National Quality Forum. Now these measures, as I mentioned, are those measures that MCOs have to report to the state and federal government on. And as you can see, these measures are oftentimes preventive and routine measures, at least under the primary care access and preventive care set. And those are the types of services that school-based health centers could offer, and it would make it a very beneficial partnership for a managed care organization because this is a prime location to really deliver those services for school-aged children. A lot of these are vaccinations and screenings and those really important preventive services that are very, I guess, a higher priority for managed care plans when they're approaching the care of children, especially those that might be healthier. And so what I would like for you all to take away from all of this is just to remember that it's important to managed care organizations that they meet their beneficiaries where they are. They're really looking for those facilities and those providers that can offer them that. And in the past, when I've spoken with various clinical leaders or policy leaders within Medicaid NCOs, a lot of them have spoken very highly of the relationships that they have with school-based health centers because it makes it so easy for them to get to the kids that they need to get to and to make sure that they're getting those required screenings and services completed. It's a lot easier for them to reach this population, and traditionally with this population, parents find it difficult to leave work to take their kids to appointments. And so if they can cut out that obstacle to providing care, they will gladly do so. And so I will leave it at that, and I'll turn it back over to Alex.
Great. Thank you so much, Ashley, for that presentation. I think that did a great job of establishing a foundation for everybody today just about Medicaid managed care, and we appreciate you sharing that information. I think the last slide especially is good food for thought in terms of the role that schools can play in really supporting managed care organizations in meeting those core goals. And I think people on this phone probably, or on the webinar probably, are well aware that schools can play a key role in meeting a lot of those quality measures. So I appreciate you sharing that information. So we are now going to go ahead and get started with our Q&A session. And so we would encourage everybody to share their questions through the questions box on the control panel. We've had a number of questions come in, so we will go ahead and get started with those, but please keep them coming. So the first question is for Ashley. So understanding that we're talking at a high level here today, what do you see as the advantages of partnering with a managed care organization for a school or school district? And so can you see any value to the MCO in partnering with a school district?
I think that's a great question, and absolutely would be my answer. I think, particularly for school-age children, which typically a lot of Medicaid managed care plans are providing coverage for, as I said before, they really want to find their members and, provide that coverage, that treatment where they are. And the best place for them to do that is where they know their students, their members will be, and that's in your school district. And so for them, I think there's a very clear value statement, value proposition that a school district could formulate to approach that conversation. I don't think you'll ever have a negative conversation with a managed care organization if you were to approach to partner with them so that they could provide that coverage for students in your school district. I think as far as the value proposition is concerned, as I mentioned before, health plans really speak the language of quality metrics. If you can prove to them that you have good reach into their members, they will pay attention. And you'd be surprised how important those routine vaccinations and screenings are, and how much a health plan can get dinged or have a financial kind of punishment for not meeting those metrics at the levels that are required. And so I think if you can speak to that, that's certainly a very big component. This is a common jargon these days, but the social determinants of health, health disparities that are focused on more vulnerable populations, especially low-income minority areas. Health plans struggle a lot, as I mentioned before, with having appointments maintained, having those children come in for not only just their routine and preventive, but if they do need a particular treatment or if they need other services, getting them in the door because it's so hard for parents to take off work. And there might not be a caretaker in the home that can take the time to take them. And so, again, that speaks to the value proposition. You have these kids in your schools for a set time every day, and if you can kind of give the health plans a platform to engage their students, they will pay very close attention to that. So yes, I definitely think there are some very key positives to health plans partnering with school districts.
Great, thank you. And Lena, do you have anything to add to that?
Well, the one thing I would add is sort of looking at it from the other angle, why a school system or a school would be on the other side of exactly what Ashley said, where we're coming from. And there are a number of reasons I think it makes good sense to partner with plans, but not the least of which, sorry, this is a little bit crass, is they do bring an awful lot of sustained resources into the schools. And, thinking expansively about the role of plans as partners, the resources include data. They include broad outreach into the community. They include reimbursements. So I think, understanding what the plans are interested in, I think the point Ashley raised about addressing social determinants of health, that is stuff the schools and the school districts really know, but we have a lot to gain from that partnership as well. Thanks, Alex.
Great, thank you. And next question, Lena, is for you. Can you share some examples of how schools or school districts are partnering with managed care organizations?
Excellent question, and I will answer that, but I am also going to put up front here a huge plug to everyone on this call. As we begin to explore more deeply best practices in different states and school systems and individual schools, I have a couple of examples, but they tend to be anecdotal. So the more of these we can put together as case studies, we would love to hear those. So I know we've asked before, but I'll put that plug in up front while I have everyone as a captive audience. Think about how managed care is involved in your schools and school districts now, and let us know so we can help highlight those. But a couple of really good examples. I mentioned earlier that in California, the health plans are partnering with a not-for-profit to do teacher education and training for outreach and enrollment. It's a really interesting and wonderful and emerging practice. In Oregon, there is a partnership between a health plan and a county health department. And the plan gives payments to the health department to provide staffing and implementation of prevention activities and programs. And the plan generates these funds through a dedicated and sort of pre-negotiated per member per month investment, which has resulted in millions of dollars of prevention activities. And what that partnership realized, again, this was the health department and the plan, was that there is a return on investment for everyone in social and emotional learning programs. So they allocated these resources in turn, or at least a portion of them, to support teacher training and implementation. And so it's a really interesting way to look at several different partnerships together. It brings together sort of all three agencies we're talking about to bring money into the schools to support teacher training and implementation. And then in St. Paul in Minnesota, and we'd love to hear more if more of the Minnesota folks are on the phone, but the St. Paul School District is contracting with 3 Medicaid managed care providers. And the district was able to get a provider agreement through the Minnesota Department of Human Services, which in turn lets the district build the plans for the services provided to Medicaid enrolled kids. And given the percentage of low-income students in the district, given the percentage of Medicaid enrolled students in the district, that the district did the math and realized it was worth the extra effort, and as Ashley talked about the paperwork burden, to become a provider and to bill Medicaid to really strengthen the school's abilities to expand access and to provide sustained access. So it's a couple of different ways that the plans are engaging in schools, and all of them, you know, are worth us digging into at a later date and thinking about how we can transport those.
Great, thank you. Oh, go ahead, Ashley. No, go ahead.
I just wanted to say, so every year the Institute puts out a best practices compendium, which you can find on the website, and I can pass that information to you, Alex. But we capture what managed care plans are doing in different categories and areas, and one of those buckets is children's health. And in last year's compendium, I think it was on page 104, there is a Virginia-based health plan, which is a subsidiary of Anthem, that partnered with schools in West Virginia to just have a timely submission of a complete medical record and a health risk assessment. And they engaged in this kind of contest, and they offered rewards to schools for the highest number of participants. And so they, I think, over the course of that 1 year had awarded something like $2,500 to one of the schools just because they had, you know, this high influx of preventive healthcare checkups and health risk assessments completed. And the reason why the managed care plan sought this relationship with the schools was because they had seen a clear decline in the number of well child visits under the Bright Futures requirements. And so they needed to figure out how to solve that problem. And so this is an example of plans reaching out to schools and creating a mechanism for not only for them to get better care to their members and meet their quality metrics, but also to share in that reward with their partners, which was the schools. And there's other examples where you can see that in the compendium throughout, and it'll give you a sense of what managed care organizations are looking for. A lot of these were programs that were set up in specific states by community programs leads, and so, you know, it'll help to capture that language and those priorities in a variety of different instances. So I will go ahead and send you that link so you can pass that along to webinar participants today.
Great. Thank you so much, Ashley. We'd be happy to share that and appreciate you bringing that up. One quick follow-up question for Lena. We had somebody ask if you can repeat the name of the state and school districts that is doing the social and emotional learning work with their state Medicaid resources.
It's the Trillium Community Health Plan Coordinated Care Organization and the Lane County Health and Human Services Department. And what we'll do is see if we can't pull up some more information on each of these and present them as case studies to everyone.
Perfect. That would be great. Thank you. So next question for Ashley. So data sharing between education and health has certainly been a big focus of this learning collaborative. And we have a question wondering if you can speak more on the barriers or opportunities for establishing data sharing agreements under a managed care organization or provider and school partnership.
Sure. So managed care organizations typically, especially with facilities, will, and by facilities I mean places like hospitals, nursing homes, and the like, they will engage in data sharing. And it won't necessarily be raw claims data, but what they'll do is they'll take the data that they do have for their members and do some data mining, number crunching, and identify kind of those high-risk areas, some sore spots maybe where they're not reaching members, and they'll engage in data sharing with their providers, especially those that they see a lot of trends with. And so as far as data sharing is concerned, managed care plans will have pretty much like a standard data sharing agreement, and it's sensitive to a lot of state and federal regulations around the nature of data sharing. And so it's not an uncommon thing, but what you'll often see is the result of that data sharing. You won't necessarily see the data itself. And I will say that there is a lot of state sensitivity across the board. The relationship between managed care organizations and states is one of a client kind of customer relationship. And so for the managed care plans, the states are their clients. And the nature of the data is that that data typically will belong to the state. So that's why you'll see from health plans a lot more report building in which they'll share reports with kind of missed appointments, non-compliance on the part of patients with their treatments, medication adherence issues, but you won't necessarily see kind of a two-way street of data. I hope that speaks to the issue. If it needs further clarification, I'm happy to look at that.
No, I think that's a wonderful job addressing the question. Thank you. So another question for Ashley. Sorry to keep firing them at you, but people clearly were intrigued by your presentation. So with the history of managed care organizations, do you know of any research that shows that they do have improved outcomes, reduced costs, improved health, etc.? And if so, we could share that research, or if you can speak briefly to any findings from that research, that would be wonderful.
This is an excellent question. I think it speaks to the question of the value of managed care, which is something that politically and policy, as far as policymakers are concerned, this is something that's been looked at a lot over the years, but has not necessarily been well researched. And it's partly for a couple of reasons. There's some issues with data lag, and it's because of infrastructure issues and resources across the states. There's different requirements for the submission of data to states and then from states to the federal government. And so when you would like to have a timely analysis of cost savings on the part of managed care plans and align that with improved health outcomes or improved quality, you don't get to do that in a timely manner. So my winding way of saying that there are some studies out there, they are dated. Some of them are inconclusive, and that's just because you don't get the full picture of data. And so I can do some more digging and connect with my colleagues at MHPA, Medicaid Health Plans of America. But it's hard to pin a specific kind of peer-reviewed journal article or official document on cost savings, ROI, improvement in quality. Now, what you'll see sometimes is individual state Medicaid agencies or trade associations for health plans within each state will provide a document like that, and that would require a little digging. I'd have to know which states you were looking at. But there's some articles out there. I could share those with anybody who's interested in Alex. I'd be happy to send those to you. But they're not necessarily the most timely. I believe they're dated to like 2008 or 2007 is the last one. But it's just a hard area to kind of quantify. But what you'll see a lot are examinations on kind of fraud, waste, and abuse. So comparisons between unnecessary services and any other kind of fraud-based activity that managed care organizations are able to prevent. And you'll see, depending on the state, as I mentioned, perhaps some reports there. So I'd be happy to take a look and send along what I currently have as well, but I'd need to know a little bit more about which state you were really looking at.
Great, thank you, Ashley. And certainly, if there are articles that come to mind that we could share with the group, we certainly can do that. And then for the person that asked that question, if they are interested in specific information from their state, certainly follow up and we can work on getting that to you. So the next question is for Lena or Ashley, and actually I can take a shot at answering it first, is a question wanting to know if there are any models that show the role of school nurses and how they interact with managed care organizations. And I know none of the examples Lena spoke to specifically spoke to school nurses, but one example that we do know that there are a handful of examples. Certainly if anybody on this webinar is aware of examples, we would love to highlight those. As Lena said, we're really eager to collect these case studies and share them. So please follow up if you are aware of specific examples of school nurses interacting with managed care organizations. One specific example I know of is in Madison, Wisconsin, and the district has a long-term contractual relationship with a number of managed care organizations there where they pay part of a school nurse's salary with the specific goal of trying to increase the number of health screenings their Medicaid members get. So certainly recognizing the role that school nurses can play in having a broad reach of the members of managed care organizations and supporting that role. So that's one example. I am sure there are others, and we would love to collect those and highlight those. Lena or Ashley, are you aware of any other specific examples?
This is Ashley. I can think of one, but I can't tell you the exact financial mechanism. So United Healthcare, Community and State, which is their Medicaid product, they have a program that addresses childhood obesity in kids ages 6 to 17. And it's a program that they've got across multiple states. I think it's Wisconsin, Minnesota, Texas, Kansas, and a couple others, but they partnered with school nurses, among other local clinicians, to refer children and teens who qualify for this particular weight management program. And it was a program that was offered to everyone aged 6 to 17, so they didn't even have to be a member of the health plan. They were kind of doing a broad, sweeping net across the state to get that those weight assessments and get the kids involved in the weight management program. And so I'm sure there's some, aside from a claims mechanism by which you would pay the provider, I'm sure there is some other contractual agreement that they had to create to kind of broadly sweep across the state and the schools in the state. But I'd have to do a little back and forth with my partners at United Health to get a better understanding of that.
That would be wonderful if you are able to do that, and we can certainly share that information with people on this webinar if you're able to find more details.
Sure.
So another question, probably for Ashley again. So from a national perspective, do you see managed care organizations demonstrating a preference to contract with community-based providers where the services are delivered in a community as opposed to school-based providers where the services are rendered in a school setting. And if you do see that preference, do you have any suggestions for how to overcome that obstacle?
That's a great question. I don't think that there would necessarily be a preference in this case. I think typically community health centers and FQHCs, or federally qualified health centers, are the quickest relationships to make for health plans in a given area. Everyone knows where they are and who they are, and they're already credentialed, and they've gotten through that whole process. So I think that's just by nature of it being so easy that they partner with more frequently those providers. But I don't say I couldn't foresee a health plan, and I don't know of any data that says a health plan would avoid a school-based health center in favor of another provider or facility. And I have to say, when I've spoken with health plan chief medical officers, they will rave about school-based health centers because it's just so easy for them to get to the kids that they really need to get to. There was one discussion that I had with a CMO who preferred to go through schools to get a hold of teens and to get them their family planning services and supplies because, as you know, it can be tricky with having parents involved in those discussions, and the health plan very, very much took it seriously as they addressed those needs and made sure that both boys and girls had access to family planning so that they could avoid unintended pregnancy. And so, I can say that health plans definitely see that value of the school-based health center, and it's with a different lens than I would say a community health center or an FQHC that's not necessarily the right way to meet those school-age children. So I don't think you'll find that there is a preference, and if you speak to anybody at a health plan, I don't think they would discriminate against the school-based health center. I think they definitely see a different value for a different purpose, and I think that's a good thing. It's dependent on the eligibility group, but you're really meeting that need when you can offer them the opportunity to interact with their school-based or their school-age children.
Great, thank you. So I want to be aware of time. We have 2 more minutes until our hour is up. So we're going to do one more question, and then certainly we will follow up with folks that sent in questions that we were not able to get to on the webinar. So the last question, which I do think is an important one that we haven't addressed, is the issue of carving out services. And so this person wants to know if most states include school-based services in their managed care plans, or if most end up carving them out currently. And if you're aware of any preference on how these services get handled from CMS's perspective. So I think any insights that you're able to offer in terms of that would be tremendously helpful for this audience.
Sure. So I would say, so carving out, and for those of you who don't know what carving out means, that's just removing a specific set of services from a managed care contract and only offering them in fee-for-service. Now, carving out it's usually assigned to specific services rather than providers, and the only instance that you'll see that not really following is with specific specialized services, things like kind of chemotherapy or hemophilia management, dialysis, things that you wouldn't typically offer in school-based health centers. So as far as carving out school-based health centers, I don't see a state going towards that just because that's it's a facility in which primary care can be offered, and that's not something you'll see carved out of a managed care contract. So I would say I can't answer the question about CMS off the top of my head, but I highly doubt that they carve out school-based health centers and the services that are provided there, again, because that's part of the cadre of kind of primary care and preventive screenings that are common across the board. So I would say my gut would tell me no, that they're not carved out, but I would be happy to look into that.
Great, thank you. I know, Lena, do you have anything to add on that one?
No, but I've noted it as a topic to dig into more at a later time for us all, and we have a deeper chance to think about it.
Great. So we will certainly do that. Fantastic. So we are at the top of the hour, so we're going to go ahead and wrap up this webinar. Contact information is included on this slide, and as Ashley said, she welcomes people reaching out to her with additional questions, so we really appreciate that. And we will be following up with an email to everybody on this webinar with a link to the recording of the webinar and slides, so please feel free to share that with your colleagues. And just I wanted to extend a thank you once again to Ashley and Lena for their wonderful presentations today and answering our questions. And thank you to everybody who was able to join the webinar, and we will be in touch soon. So thank you and enjoy the rest of your day.